In any case, this is the first Global Health Institute seminar of the semester and the first of 3. And indeed, all of our seminars are planned out for the remainder of the this academic year, all the way through May. So it's typically the last Thursday of the month at 4 o'clock, and we have chosen to stick with a Zoom format because it gives us the largest crowd, group, and reach. So on any Thursday at the end of the month, this is where you can hear a speaker talk about their research or experiences in global health. So I really want to thank all of you who have come today. Really appreciate it. It's a tremendous support for our Global Health Institute, which is small but active, and this is one of the successful parts of our program. So a couple of things today, and I will go ahead and start my talk because it will help me lead into the next thing that I'm going to say. So I wonder, is the slideshow visible?
Yes.
Okay, great. So today I'm going to be talking about network transmission of M. tuberculosis in Kampala. This is work that I do with Dr. Noah Kiwanuka at McCary University in a collaboration with the University of Georgia. Now, I know that we have invited some individuals from Emory to this particular seminar. Emory is the recipient institution of a new award called Tuberculosis Research Advancement Center, or TRAC. There are 4 or 5 of them around the United States, and Emory is leading the one for developing tuberculosis research in Georgia. And I'm fortunate to be one of the program faculty, as is Dr. Sakandi. So unfortunately, I couldn't find the logo for the track to put on this first slide, but you can imagine TRACK is down there at the bottom. I see. So Paula, is that your, Adeneki is reminding, yeah, thank you. If we'd like to get a list of people who've attended today's seminar. So if you can just type your name and affiliation into chat, we'll record that. Really appreciate it. All right. So I'm going to talk about network transmission and TB. There's a lot of background that I could and should go over, but to condense it, I will just make the point that there's variation in the incidence and burden of tuberculosis around the world, and that's illustrated by this particular map. And not a surprise, the highest incidence per 100,000 population is falling in sub-Saharan Africa and in parts of Southeast Asia. The work that I will present is from here in Equatorial Africa in Uganda, where the rates of tuberculosis are 200 to 300 per 100,000. One of the research questions that I have is, why does tuberculosis persist in these regions around the world? There's a very simple answer that I call the replacement principle, and that is, as long as one case of tuberculosis is replaced by another in a population, elimination of tuberculosis cannot be achieved. Those of you who know something about epidemic models know that this is the effective reproductive number, or something like R0. If each case is replaced, the disease will never go away. And it seems as though in many parts of sub-Saharan Africa, this is the situation that we find ourselves in. And I think we need to really focus on the factors that lead to persistence if we really want to curb the epidemic of tuberculosis there. So the creation of any new infection that may ultimately lead to TB disease really depends on two things. One is the contact rate between infectious cases and susceptible contacts. The second is the transmission probability given contact. So I'm going to review some of the second part, the transmission probability, and then spend a little more time talking about contact rates. Now, this is a brief model of the natural history of tuberculosis. Those of you who are in the field know that this model has been elaborated and developed further. But I think for the purposes of today's presentation, I'll use the simpler rendition, where we're looking at the natural history of TB and trying to understand the transmission probability. And we're using the secondary attack rate for TB as a way of estimating that secondary attack rate. In comparing individuals who go from an uninfected state to full disease, we're estimating the secondary attack rate of TB disease. If we're looking at the individuals who go from an uninfected state in the household to the infected state, that's the secondary attack rate for infection. And then this is actually not an attack rate, but a probability describing the probability of progressive primary disease. That is, what's the probability of becoming diseased given that you're newly infected? And the origins of that analysis began in a household contact study that I designed in 1995. And believe it or not, although I'm not currently involved in it directly, that study continues to this day. Briefly, we identify index cases and their household contacts and community controls. And in the cross-sectional aspect of this study, we evaluate baseline infection. We've used, this is old enough so that skin testing, it was the mode of diagnosis of latent infection, and active tuberculosis using sputum microscopy and microbiologic methods for detecting TB in both households and community control households. This study I began with Gilbert Bukenya, and then when he moved on, David Gwatude and Sarah Zalwango were the Ugandan collaborators that helped really push this study along. There are many results, most of them published at this time, but this is sort of a summary figure of the secondary attack rate for TB. It turned out to be 3%. Now, it's important to note here that methodologically, we only counted transmission events when the isolates from the index case and the household case were the same, so that we could infer a chain of transmission. If they were different, we didn't count them in this particular analysis. So 3%, and interestingly, that's about what many household studies since then have found, 3 to 5%. And when you look by age, it's higher in young children and higher in the HIV infected individuals. Now, we developed methodology and in the paper where this was published for estimating the secondary attack rate of infection, where, as far as I know, no one else has done a similar analysis. And the short of it is about 50% of individuals living in the homes of index cases in Kampala were newly infected with M. tuberculosis. Interestingly, this risk of infection did not vary by age Very young individuals had a similar level of infection as older individuals in the home, nor did it vary by HIV status. So we then used the secondary attack rate for TB, secondary attack rate for infection, then to calculate the probability of progressive primary disease given new infection, which is just 3 divided by 47 or 6%. And now you see the excess risk for the progression of disease in children, close to 10%. So if a child is newly infected, their risk of disease is 10%. And in HIV, it's even higher. It's close to 20%. So these were estimates of the transmission probability of tuberculosis in the household contact setting. So what are the take-home messages? Well, the household is an environment for intense transmission of MTB and the occurrence of progressive primary disease. And it's the fundamental logic for household contact investigation. Children in HIV seropositive contacts were at the highest risk for disease. And I didn't show the calculation, but the daily risk of infection from household exposure is between 0.7 and 2%. So I did a little arithmetic to get that. So on a daily basis, someone is accumulating about a 1% risk of acquiring infection by living in the home of an index case. Well, during the process of that study, we observed that the TB cases often went to work, they socialized, they did things outside the household. And we were beginning to get interested in the nature of that interaction outside the household. And that led to our interest in social networks, because the social network would provide some kind of structure for us to use to understand the interactions that occurred outside the household itself. So our theory, we moved from the household contact, and we just said, well, the social network is comprised of the household and extra household contacts, and that we believe that if the household contact is an intense environment for transmission, some of that intensity will diffuse out into the social network. And that was our working hypothesis with our social network study of TB transmission. As I drew this out slightly differently than before, but it's essentially the household contact where you find the index case and the household contacts in the case and neighborhood controls. But what was different about this compared to the previous study is we used a systematic way of listing and identifying and evaluating extra household contacts, not only for the TB case, but for the index control. And as before, we measured latent TB infection and disease and did a variety of other measurements at the same time. Now, this study, Dr. Kiwanuka is the PI on it with me. Sarah Zalwango is the field director of the project. Robert Kakairi organizes it here, and Ronald Galawango and Samuel Kiramunda added some of the molecular epidemiology that we needed. All right, so this is sort of one of the main results of the study, where on the left side of the figure, we have the prevalence of TB infection among the case contacts. The solid bars are household contacts, the hashed bars are extra household contacts. And what you can see is that there appears to be an excess risk of infection if you live in the home of the index case as compared to the extra household contact, so this is 56 or 7%, this is around 42 or 3%. So what I would say here is that without a control population, it would be tempting to conclude that these individuals encountered a high risk of TB infection as the result of their being in the social network of the index case. Fortunately, we have a control group, and what we find is that the risk of TB infection in the extra household contacts of the cases is only a small little bit higher than it is seen in the general controls of the community. And this turns out to be 3 or 4%. So it raised it indicated to us that actually there's a great deal of community transmission going on, and that the being a member of the social network, an extra household member of a social network of an index case, only incremented the risk of infection a small amount. That was unexpected and a bit of a surprise. And we went forward and calculated a very standard epidemiologic measure, the population attributable fraction of tuberculosis infection. And without going through a lot of these detailed numbers, I'll just draw your attention down here, where if an individual had recent contact with TB within a year, or could recall knowing or being part of a social network of a TB case at any point in time in their past, we found that the population attributable risk was only 11%. For household contacts, it was 7%, and for extra household contacts, it was 3%. So contrary to what we were expecting, we would have expected this to be 40 or 50%. We're seeing that known contact with a TB case, as if you were doing a contact investigation for TB control, if you were doing that perfectly, you'd only reduce the prevalence of infection by 11%, meaning that most of the infection in the community is not explained by social networks, by the knowledge or inclusion within a social network. Again, a striking finding. Now, we did a sensitivity analysis where we looked at all possible combinations to calculate the secondary attack rate for TB and came up with this curve. I know it's a little bit hard to read. We have the prevalence ratio of exposure, the probability of exposure given infection. And when you work with prevalence ratios and exposure probabilities that you find in published papers, the population attributable risk rarely gets close to 20. It's all down in this deep blue area, suggesting that that our findings in Uganda are quote unquote generalizable, meaning that most places the population attributable risk is going to be quite low. And that poses a challenge. That kind of segues to what we're going to look at next. But I've got a little more about the social networks to tell you about before I move on. So in the study where we calculated the population attributable risk, we actually had 123 TB cases and 124 matched controls. And we used our interview techniques and some machine learning techniques to identify or to create the social network of these individuals. It turns out that this network has 11,739 people, a little more than half of them being male. There are many, many connections, thousands of connections between individuals in this network. And the median number of connections is around 10. So each dot, each little circle represents a person. On average, each person has about 10 connections to other people in the network. And the clustering in the network is quite high, suggesting that there are groups of people that know one another, so it's not as though everyone is a single connection in there. Now, one of the things that we did is we took the strains of tuberculosis from those 123 index cases, and we did whole genome sequencing. And we found a number of strains that were linked together, a few from lineage 3 and a greater number from lineage 4. Lineage 4 is the most common lineage in Kampala, and so it wasn't surprising for us to see this. Now, the red marked areas here represent strains between two people that had 0 to 12 differences in the single nucleotide polymorphisms, or SNPs. So the fewer the SNPs, the more alike the two strains are. Blue was 13 to 50, and green was 50 to 51, and so on. So you can see that we have a pretty strong cluster here. We have some clusters in the lineage 4, where we have the not very many SNP differences. The 12 is to some extent arbitrary, but it seems to be a number that others have used. So what we have done, we identified these clusters, and I think this is just lineage 4. We had 12 clusters of tuberculosis cases. We could count them, but this is them. And within those clusters, we have 23 pairs of cases with genetic links defined as a difference in the SNP of 12 or less between the isolates, meaning that the isolates look a lot alike. Now, what is surprising is that in only 3 of the 23 pairs are we able to identify links within that social network that I showed you. And the path length of those links is just 2. It's not a direct link. It's not a step of 1, but a link path of 2. And surprising to us was that 13 of the 23, or 57%, although the microorganisms were very, very alike, as if they were transmitted between two people who would have known each other, 57% of individuals, there was no path between them in the social network. They weren't linked in the social network. So it starts to make us think that, well, maybe the social relations is not the key driving force for a cluster transmission of tuberculosis. So we looked at the distribution of TB in Lubaga. This is some of the same strains, but a different analysis. In this case, we had 69 strains, and we used a program to actually create the transmission tree as opposed to the phylogenetic tree. And what we identified were actually 6 clusters of transmission, with this box being the first case in the network, and then subsequent cases. And if you look carefully, you can see their arrows. So with TB, there's directionality to the transmission. So this person gave it to that person, and that one, and that one, and this person to here. This person spread within this cluster, and this person spread that cluster, and so on and so forth. So we had 6 clusters, and these individuals turn out to be incredibly important because they move M. tuberculosis from one cluster of people to another cluster of people. So if you want to think about it, they're sort of the individuals who are amplifying the epidemic. Now, we color-coded these clusters, and we said, how are they distributed in our social network? Well, this is the same social network as before, just shown a little differently. The gray represents all the connections, as opposed to that round circle. We just plotted it slightly differently. And these colored clusters are overlaid on top of the social network. And I think if you look at it, you will agree with me that it does not appear as though these colors are clustered within the wiring diagram of this social network. You know, it's not as though we see all the blue down here and the pink up here and the yellow over here. We're not seeing that pattern at all. In fact, when we look at the degree in the social network, meaning the link, the number of steps away two people are in the network, and the number of steps away they are in the transmission network, we get, you know, maybe a slight relationship, but it's not statistically significant, indicating that there does not that the social relationships as measured by the social network do not explain the clustered nature of transmission that we clearly see. So another method, same result. So we're really, what we're doing is we're using two assays, so to speak, one, this one, the other, this one, and we're getting a concordance of results. So it gives us greater confidence that in fact, the nature of the social network as measured using traditional social network methods, research methods, is not an explanation for the clustered transmission of tuberculosis. So that's a major take-home point. All right. So we started thinking about transmission beyond social networks. And this is our current model that we're working with. And that with each TB case, they have what we conceive of as a contact network. All right, that's this outer one. The contact network actually contains the social network, which includes the household network. Now, I'm showing this just graphically to give you an idea of how we're approaching this problem. This part of the network we call the Aristic Network, and all this word means is undefined or, you know, unable to measure. So there's a lot of this network. We don't know how to measure transmission. We like the household contact design and the social network because we could enumerate contacts. We could measure exposures. We could calculate the epidemiological measures that we teach in 70-10 and 70-20. And we could conceive of individual interventions as the result of our work. However, in this Aristic portion of the network, we are not able to enumerate the contacts. We don't know how the index case interacts in this portion of their contact network. We're not able to measure exposures. How often are they exposed? There's no standard epidemiologic measures to use in this portion of the network. And finally, if we're going to intervene in this part of the network where we don't know the individuals, our interventions would have to be population-based with you know, an averaged expected outcome. Now, the good news is that there actually has been research on transmission of tuberculosis in the community. Household contact studies now are abundant. Even before that, there are outbreak investigations. There's a type of study that's referred to as the annual risk of infection. A very powerful form of epidemiology is molecular epidemiology. An example of one of that was the whole genome sequencing that we used. A group in Europe have used time activity diaries as a way to understand how people mix in the community. There's a group in South Africa that is doing ventilation studies to try to understand how much the organism, how infectious are people with tuberculosis. And then there are the mathematical modelers who, you know, can create marvelous results with their mathematical models. our research seems to point that, but you'll notice there's no social network on here, though there are quite a number of studies ongoing about social networks in TB. I believe that the social network is going to lead, it will not explain the full dimension of transmission of tuberculosis in a community. I believe that one has to look at geospatial social networks. And to that end, we are doing a study called Mapping Tuberculosis Transmission in Uganda. It continues to this point. Here, we follow the same design. We've completed our case enrollment of 300 people. We have networks on most of them. We have self-described geospatial networks. We use cellular phone metadata to obtain the movement of individuals 6 to 12 months before the diagnosis of TB. TB isn't spread after it's treated. It's spread before it's diagnosed. So this is an unbiased way for us to get information about mobility prior to diagnosis. And we're using microbial networks for the whole genome sequencing, similar to what we did before. But now our focus is not exclusively on the social network, but the geospatial social network that is created by the movement of TB cases going about their daily lives. And here, Dr. Noah, Sarah, and Robert are all involved. So let me tell you a little bit about how our networks are come about and how we're approaching it. So this is a TB case who comes to one of the clinics that we work at. We tend not to work at the large referral center, but we're working in smaller clinics distributed around the city. So we believe our patients are not the sickest. They are actually more representative of tuberculosis than those who present to Malago Hospital. When this person comes in, we have very well-trained field workers who ask this individual, where do you live? And we go to that place and we geomap the coordinates of that house. Then we say, where else do you spend your time? Oh, I spend time at my brother's house. We go there and we geomap the brother's house. Where else? Well, I go to the market here, and this is a pub down here that I like to go to. And oh, I happen to work over in this place. All of these locations, this person goes and spends time at before the diagnosis of TB while they're infectious. Now, it turns out that because this person has to move around the city, they use the transportation system. And because they're sick, they, even though they haven't had the diagnosis of TB made yet, they're still seeking care sometimes, so they may go to a hospital. Now, after we identify where individuals have gone, we ask them, what members of your social network spend time with you at that location? And he will tell us, my wife and children spend time with me at my home. Good. How about over here at your brother's house? Oops, sorry. And the children go to school. How about here at my brother's house? Well, my family and my brother, we spend time together there. How about at the market? Well, I go to the market with my wife. And how about at the pub? Well, my brother and I spend time at the pub, and I've got 2 friends at work who also spend time with me at the pub. So you see, what we're doing is we're starting to populate these locations with members of this person's social network. Makes sense? Well, now we start drawing connections. We make a connection between 2 geolocations based on whether there are members of the social network in both of these geographic locations. And I'll just click through these without going. Now, I just gave you a preview. Now, it turns out that when this individual goes to the taxi park, there are many, many people at the taxi park that he does not know. He would not list them in his social network. Yet, while waiting for the van or the taxi to go, he might be sitting inside this taxi with these other people for up to an hour. Or he may be sitting just chatting with these people at a location inside, out of the rain. He would not list these people as social network members or even know who they are, but they're part of the contact network. Why? Because this person would have had adequate contact with them, even though he doesn't know them. The same, we illustrate the same thing here in the hospital. And as a result, we're able to draw these dashed lines to say this person goes to this area and they're geographically located there, but they're not interacting with anyone in their household or social network. Now, another interesting point to make is that here, when he goes to the market with his wife, he's not just going with his wife isn't the only person there. There may be many other individuals that he interacts with in a sufficiently close way to transmit tuberculosis. But again, he wouldn't necessarily list that person as a member of their his social network. So I think I've gone through how we do this, and I think it makes sense. It was well, now we have the data. What do we do with it? Well, there's a type of social network called a bipartite graph. When you say graph, it's kind of out of mathematics. When you say network, it's kind of referring more to the study of networks in the real world. Let's start with the middle part. As I explained, our hypothetical case identified locations, in this case A, B, C, and D, where he spent time. And at each location, we asked, who did you interact with there? Well, I interacted with 1, 2, and 3. At B, who did you interact with at B? I interacted with 2 and 5. At C, 4 and 5, and D, 5 and 6. All right, that should sound and look very familiar. Now, with that information, there are 2 possible projections that we can make from this bipartite graph or network. One is a person or social network projection, meaning that these people, 1, 2, and 3, are all connected, and the connection between them is the geographic location, A. What connects 1, 2, and 3 is location A. What connects 2 to 5 is location B. What connects 5 to 4 is location C. And what connects 5, 6, and 7 is location D. So in this graph, we look at the people as the nodes and the locations as the connecting lines or edges, they're often called. Now, we can do it the other direction, where the location projection is looking at geographic locations that are connected by the people, similar to what I showed before. So A is connected to B by person number 2. B is connected to C through 5, and to D through 6, or 5 to D, and then D is connected to C in this manner. So here, the locations are the nodes, and the connections are the individuals that are shared at those different locations. So now we have a way actually to begin analyzing our data by looking at it as a bipartite graph. So in Rubaga, we have the Geospatial Network. It currently has 222 TB cases. 70% of them are men. You can see there's some HIV. The social network members, there are about 3,500 social network members identified in the group. Household contact only represent 9%, extra household and extra household 18%. The majority are extra household contacts only. And then in this interviewing process, we identified almost 4,500 unique locations, 13% indoor, 57 outdoor, and 30% kind of both. This just shows the frequency of contact with the location over per week and the amount of time spent at that location. So these the most common thing is less than once a week with a short period of time. And you can see as you go up this way, individuals are spending more time, but and often doing it daily. Those might be members of the same household. So it's a way to look at time spent and possible overlap for infection. Now, this is an example of a geospatial network of an individual. The red represents the social network of the individual. So I actually don't know who the index case, the index case is right here, 001.1. Yeah, is in this group down here. So you might imagine that this is the person's home, and these are members of the family living in the home, maybe with the exception of that one. But they also identify these people up here as part of their social network, but it's geographically in a different location. Of note is all of these green dots represent locations where the index case goes and does not identify any social network members. This came to us as a big surprise that they were really going places, quite a number of them, and they didn't identify anyone in their social network at those locations. Now, I'm going to try to harken back to that model. If this is our social network, you know, our TB case in their geographic social network, this may be a representation of the geographic distribution of the contact network. Because remember, each one of these places is geographically located in that Aristic portion of the network. So, you know, we then went ahead and we used one of the projections, the social network of TB cases and contacts. And here it is. And unfortunately, I can't see everybody's face, but I think I just lost 75% of you. You're looking and you're kind of laughing underneath your, you know, you call that analysis? That just looks like a fried egg or something. You know, how can you make any conclusions out of jumbled data like that? Well, all I'd say is this looks pretty jumbled too. You've got distributions over 5, 6 different groups. You know, each distribution is different. The numbers of people are different. This has lots of data in it. And you were taught in your epi classes about mean, median, mode, variance, standard deviation, and so on. And that these things help you take this complex data and distill it down into numbers that you can then compare. The mean in this group as compared to this group. The standard deviation in this group as compared to this group. You've learned all that by virtue of your statistics courses. Well, I would argue that there's a very similar, though slightly more complicated, way to analyze networks. So when we look at the social network projection, this is the same as before. It turns out that there are a series of statistics, just like mean, median, mode, variance, etc. and here they are. What's interesting is that when you analyze a network, the way you do it is you take all pairwise people and you analyze the relationship between those two randomly chosen individuals. So in this particular network, there are 3,322. So how many pairs are there? 3,322 times 3,321. If you do the arithmetic, it's a little over 11 million. There are 11 million unique pairs in this network. And that's the unit of analysis. You ask, what percentage, how many links are there between those pairs? Well, there are only 17,900. That's easy. We're just looking at two pairs and asking, is there a link? The mean degree, that's even easier. You take each one of these 3,022 and you ask, how many links come from that individual? On average, it's 11. Very similar to what we found in the previous network where it was 10, interestingly enough. Now we get into some other statistics such as edge density, and the clustering is just like a correlation coefficient. In fact, that's what it is. So we understand correlation coefficients, meaning the proximity that people have. Now we get into some things that are particular to networks, and that is how many components. Not all networks are fully connected. So it turns out that there's 7 different components inside this network. And I can guarantee there's one giant network that connects almost everybody. Most of these components are pretty small. The other interesting statistic is the average path length. So if you take 2 random people, just randomly select 2 people and ask, on average, how many steps, how many links are they apart? It will be 3.7. Some of you may have heard 6 degrees of separation, Kevin Bacon's story, right? I'm not hearing anyone laugh, but yeah, a big deal was made out of it. A guy, claim was made that the entire world is within just 6 degrees of separation. And this is where that came from, or this is not where it came from. This is representing the degrees of separation between any 2 individuals in this network. So the diameter is the largest average path, and I won't talk much about this degree exponent. But suffice to say that we now have statistics that take this complicated looking distribution, for lack of a better term, and because we're looking at all possible pairs, we can begin to understand the inner dynamics or the inner structure of this network. So I spent a lot of time on that to try to convince you that is the case. It's the basis of network science, and it helps us understand the structure or topology of networks. Now, let's put network science beside. If you look at this network, you'll notice something. A lot of the TB cases are in the middle. For some reason, the tuberculosis cases are very central and highly connected. The average degree of a TB case is 74. The average number of social network members that TB cases have is 74. I don't think any of us would list 74 friends or relatives. These TB cases are highly connected. That has implications for transmission. Connect people from different clusters in the network. They seem to be connecting people across different clusters. Now I'm doing the geospatial projection of the bipartite network. This was the social network projection. This is the geospatial projection of the network. Sorry, it seems to be a little bit out of focus. But now here we see the size is 4,500 locations. I showed that before. 66,000 possible links. The mean degree is 30. And if we compare it here, it's much higher than the mean degree of the individuals, meaning that these geographic locations seem to be more connected. The clustering is not as high as seen in the individual networks. Components seem to be about the same, but look at the path length is one degree shorter. So it turned, and the diameter is smaller. So it turns out that although this is a bigger network with more, it is a more compact network, meaning that any two geographic locations where TB cases encounter social network members or people outside their social network, it's an actually more compact, smaller place for TB to be transmitted. Place meaning network place. Again, this figure has a lot of interpretation and meaning, but for the sake of today, I will just bypass that. Now, when we look at the geospatial network of extra household contacts only, we see it looks like this. There are about 2,000, 16,000 links. Mean degree is pretty high, getting 16. Clustering is smaller. There are more components, meaning that outside the household, things may be broken up a little more. But here, interestingly, the path length is small again and a small diameter, suggesting that the household, when you move out of the household into the extra household setting of people in a social network, it actually is a fairly small group of people, with meaning the network is more compact. When we look at geospatial network without social network members, this is what it looks like. We'll hone in on, interestingly, there are more locations here than there were in the individual network, a similar kind of links, a high degree of clustering. Compare before 0.3, now we have these locations in these areas are highly clustered, meaning that if one person is going to one location, odds are they're going to lots of locations around that location. That's the clustering interpretation. There are many, many components, meaning that there are lots of individual places where they're not really connected at all. And the path length is bigger and the diameter is bigger. So I don't really know what to make of all of this yet, except that these locations where people spend their time are highly clustered, bring together other groups of clusters. We looked at indoor and outdoor locations, and you can see that indoor locations, there's more clustering, shorter path length, smaller diameter. If TB is being transmitted indoors, the networks are more compact as compared to the outdoors, though there's more clustering outdoors. When we look at the use of cell phones, these are all the cell phone towers that the 123 TB cases activated as they moved around the city. Kampala is right here. This is the whole of Uganda. From down here, this is Rwanda, Tanzania, Kenya, the DRC. TB cases traveled throughout the entire country during the period of time prior to diagnosis. So just the mobility, these are infectious people. They had to travel some way. And unlike the US, where we hop in a car by ourselves and drive a long way, that is very uncommon in Uganda. So they're likely hopping on trains, buses, taxis, and so on. And it turns out that this road, there's a road here, it's called the Trans-African Highway. And interestingly, this is the same route in which HIV was transmitted across much of sub-Saharan Africa. So we have evidence that TB cases are highly mobile and they're engaging a wide geographic network in the process. Just to give you an idea of the top 10 settings by indoor and outdoor. The indoor locations, home, not surprising. Hair salons turn out to be a very common location. Hospitals, worship centers, workplace, relatives' homes, bars, restaurants, and mobile money locations. These are the places where people are spending their time. Outdoor locations, work, groceries, taxi bus stations, trading centers, Boda Boda station is a transportation center, a market, and so on. So we're in the process of trying to paint the picture of what's the, when we say these networks are distributed or geolocated, we're trying to add some context to that by saying people are spending time at home or in a clinic or at a worship center. And each of these would have its own interesting intervention if we were to go that route. All right, how am I doing on time, Paula? Oh, I'm over. Okay. So as much as I'd like to present to you information about mobility of individuals, I am going to forego that. Sorry, and just summarize or finalize by this diagram that we're in the midst of this, multi-year study in which we're collecting geosocial networks through interviews and GIS watches. We're using cell phone data to understand mobility networks. And we're combining this information into an epidemiological network. And I've shown you some of those networks. We are also collecting isolates from all of the 200 or 300 TB cases. We're doing genotype clustering and whole genome sequencing to identify the genetic distance and phylogenetic data. And in other words, look at the microbial network that is present. And then with some statistical inference, we hope to be able to geographically locate where a lot of these transmission events are occurring. We've looked at this, we've done this analysis, and I showed it to you on that social network and showed there's an absence of clustering. We're hoping to use the geographic network and be able to say that the geographic social network actually explains the clustering of transmission better than the social network alone. Stay tuned. Hopefully by, early next year, we'll have that answer. So thanks all. I have time maybe for one or two questions.
Yeah, thanks for a really interesting and exciting peek into the data that y'all are collecting. So if we have any questions, you can just use the reactions, raise your hand, or just unmute yourself and ask. I think we have time for one or two.
I know. Oh, I see.
Okay.
I saw Andy.
Yes,
I was
Andrew.
going to ask him if he had a question for me.
This is just beautiful work, Chris.
Thanks.
And it's really interesting. At some level, it's also not at all surprising.
Mm-hmm.
And you're assuming you started off by assuming for purposes of constructing the model what might be the typical transmission risk per contact.
Yeah.
But in point of fact, we know that's highly variable.
Yeah.
And it reminds me, for example, of what we see in the TB trials world, where we think we give everybody a standard regimen.
Uh-huh.
And so everybody should get the same level of treatment from that regimen. And we have now realized over the past couple of decades that actually that's not the case at all. Some people get very effective treatment because they absorb the drugs well and take them regularly, and they get high levels and the drugs get all over to where they need to get. And they don't have places that are really hard to get into. And other people absorb the drugs well, are irregular, and have all kinds of pathologies that make it very difficult for the drug to reach the bug.
Mhm.
In this context, it's a bit, one returns to that issue of both super spreaders and individual vulnerability. And so I'm wondering if you could say a few words about how you think about that in relation to what you're seeing here.
So that's a good question. Thanks, Andy. In fact, it's one of the things I've only showed movement and patterns of information from people with TB. And we are trying to get the funding to look at patterns in movement of individuals without TB, so we can get a better handle on the nature of mixing between individuals with TB and those who are susceptible to it. What we find is that these networks are all the same shape and have virtually all the same characteristics. They're referred to as scale-free networks, and scale-free networks are characterized by hubs or locations or people that you refer to super spreaders. It's like there are super spreader locations in Kampala that TB cases frequent in their daily lives. And what we want to ask is the next question: are they frequenting special hubs that somehow there's a preferential attachment to that hub, or are they the same location that the general population would go to? And I don't know the answer, but I'm thinking that TB cases live lives that are not too different from the average citizen in Kampala, so that they are actually transmitting in these hubs. And that gets to the whole question that you referred to about variable transmission, for sure. But I'm starting to think, the aerosolized transmission, we need to understand more about the nature of this casual type of contact and transmission. I think that's where some of what this work will lead us. I saw Sarita's hand up there somewhere.
Yeah, I don't see her.
She may
Hey,
have-
Chris, I was going to ask you about the people without TB and their movements and social networks. So you kind of answered that just now. But first of all, just great presentation, and another reminder that we need to make a trip out to Athens and spend a lot more time with you and your team.
Yeah.
I guess a question I have is, and I might have missed it, but how do you connect your TB patients or your contacts? Are you using names to link people together, or how are you drawing those connections?
It depends a little bit. For the Bipartite network, we're simply using the information that the index case tells us of where they are and who they meet at that location. And then once we know, and we have a census of their social network. So we'll for example, let's say they say, I spend time at this beauty salon. And then we say, who from your social network do you spend time with there at the same time? So we then indicate study ID number, whatever, from that person's social network. So that allows us to make that bipartite network based on individuals that were identified by the index case. Now, when we go to start connecting networks, which we did with that first social network, we did use name matches, and that's where we use this machine learning AI kind of thing. And we have lots of data to take that 11,000 person network and add probably another, 10 or 15,000 people to it, given the data that we have. We don't have good validation on that, I will say that, but it is giving us some sort of structure of what the network might look like in the community. Well, thanks everyone for coming. I really appreciate those of you who stayed on. Hopefully I got some of you excited about what network science can offer, not only for TB, but other infectious diseases and maybe other exposures. So really appreciate it, and hope to follow up in another 6 or 8 months with the next iteration of this.
Thank you, everyone, for attending, and we hope to see you at our future seminars last Thursday of the month for the most part. And if we've got your email address, we'll try to, put you in the list to get the announcements for these. So thanks, everyone, for your time this Thursday afternoon.